Yeah. Shall we start?
Yes.
Yeah. Good evening, everyone. So today's topic is embryo transfer. It's a blend of science and art, as we all know. And along, how can you yawn? I'm sorry. So yeah, we'll go to the topic and then we'll discuss in the questionnaire. So I hand it over to Jay. Yeah.
Okay, fine. So, hi guys, and I think embryo transfer is a very important session because a lot of people who are practicing fertility would really like to sort of try to be perfect in this particular technique, because it is believed that once you do a good embryo transfer, then you might add a few percentage to your success rates. All right. Now, I don't know how true that entire thing is, but nonetheless, it's a good thing to believe that it is true, so that at least we do that technique correctly. All right. So what I'm going to do is, first I'll speak for a little while on what are the things which we do before the embryo transfer. See, embryo transfer is an OT based procedure. Okay. Embryo transfer is, this is what we do. All right. Embryo transfer is done at our place always under ultrasound guidance through a transabdominal probe on a half filled bladder. It should not be like super filled bladder or something like that, where even if you put the probe, no, the patient will be uncomfortable and wanting to pass urine. Okay, so not that heavy. Basically, the entire game is to ensure that you are trying to get the uterus into a mid position, so that passing your catheter becomes slightly easy. All right. Apart from that, there is nothing. Now, just in case there is acute antiversion, you can always give a head low while doing the embryo transfer. The head low can be given as much as approximately 25 to 30 degrees. Beyond that, normally the patient won't be very comfortable. Okay, and since this is a non-anesthesia based procedure, it's absolutely okay. You can go till approximately 30 degrees. It will allow for the anti-flexion to become mid position. So just keep that in mind. All right. So normally what do we do is, in fact, I'm standing in my ultrasound room because the other OT bowel resection is going on. So this is a screen which we have here. I don't know if you guys can see the screen here. Okay.
No.
And on that screen, unable to see. Okay. So just wait.
You need to change the background.
Yeah. I need to change the background. Yeah, so I think this is the background. Now the background is good, right? So see, this is the screen which we have here, okay, in our ultrasound room. So what typically happens is the patient can see the embryos getting loaded on that screen. Okay, all the patients can see the embryos which are getting loaded from that screen when I'm loading it inside the IVF laboratory. Okay, and normally, of course, since we are predominantly 99% of the cases are self cycles, so we normally, like every one of us, we would just verify the name of the patient. The patient would already know how many embryos they have as a couple and how many embryos they've chosen for the embryo transfer. So all these things they would already know it beforehand. All right, but of course, one small verification is done before we start loading these embryos. All right. Apart from this, very important, I normally give a tablet of piroxicam sublingually prior to doing the embryo transfer. This is given approximately 10 to 15 minutes prior to embryo transfer. I personally think it has got absolutely no benefit. Okay. But I think this has been going on in my hospital since the past 6 to 7 years. So none of us want to change it. And, it just adds to confusion. So we've not done anything else about it. Okay. I don't give atosiban injection, all right, prior to doing the embryo transfer. Though people say that atosiban may benefit, then there will be a new paper from Germany which will say no, it doesn't benefit. Then after 2 years, somebody from Ireland will say it does benefit. So in my experience, practically, we have tried it for 7 to 8 cases and we thought it is not so great. Okay, people want to try and think that when you give atosiban, the uterine contractility would go down. Okay, and once the uterine contractility goes down, it probably helps the embryo in having a slightly better implantation. I personally don't believe in that, so I don't give any form of atosiban. The reason why I don't believe in that is because the success rate of IVF in animals, okay, especially in cows and sheep, where a lot of IVF is done as a part of, animal husbandry. Okay, in that the success rate of IVF is approximately 65 to 80%. That is because they allow the embryos to be cultured up to day 7, day 8. Okay, and they don't give any atosiban. Almost all of them have a single embryo transfer, and and there is no PGTA done. It almost all of them are on single embryo transfer, and they do very well. So I think one of the things, when I was working in the institute where they were doing this cow, pig, hen, sheep, all these things IVF, one of the important things which we learned that day from the embryologist out there, who is a good mentor to me, is that even if you spit on the embryo, this was his line. Okay, even if you spit on the embryo, if the embryo wants to go and get implanted, it will go and get implanted. Understanding? So just keep that important line in your head, that you don't really need to have all these fancy things, okay, by doing the embryo transfer. Okay, after this, once the patient is given position and all your pre-assessment is done, like all of us, we put the outer catheter, right? So I am using this embryo transfer system. This is an embryo transfer system which is available in the market from Kitazato. So I think I can show it correctly. Yeah, it is from Kitazato. This is the embryo transfer system which I am using in my hospital, and I have been using it since the past 2 years. Prior to that, I was using Cook, but I just thought Cook was very, very expensive for somebody like me, so I stopped using it. Okay, this is the outer catheter. Okay, I think I can show you. See, this is the outer catheter. I hope all of you can see the outer catheter. Now, it's said that if the outer catheter is sonolucent at the tip, then it is better to do the embryo transfer that way. I don't think so. This is a non-sonolucent catheter. It works beautifully well. It has a guard here, and a lot of people try and measure the uterine cervical length prior to doing the embryo transfer. Now, I have just got a very simple system of doing that. Definitely, we don't do it. And if somebody is doing it, we definitely don't want to discourage you from doing it. But see, the outer catheter, this is a soft catheter. If you see, the outer catheter has markings here. Can you see number 1, then it has got 2, then 3, 4, right? All this is number of centimeters from the internal os. So it is believed that your catheter should be at the internal os. Okay, and then this is the marking. So this indicates your cervical length, basically. All right. So we don't do it. We have standardized it to keep it at 4.5. So if you see, my guard is always between 4 and 5. Okay. 4.5 is the standardization. So we always keep the guard at 4.5 and we pass the catheter. Before passing the catheter, we'll put a cusco speculum in the vagina. We don't use any media, IVF media and all these things to clean the cervix. We just normally clean it with a simple, I'll see if there is an earbud here. We clean it with an earbud. Okay, just an earbud. Just clean the cervix, external os. If there is any mucoid discharge or something, it will come off with the external, it will come off with the earbud and the cervix will be clean. You don't really need to sit down and clean the entire cervix and all these things, because remember, the more you manipulate the cervix, the more are your uterine contractions. Okay. So I just put the cuscos and I put the catheter. But I'll tell you one thing. I know some of my friends who put the sim speculum and hold the cervix with the Alice. Some of them hold the cervix with the sponge holder also. Okay. Even that is a technique and they have had very good results. So I personally think it must be stimulating uterine contractions as what we believe, but it doesn't really affect the outcomes. Okay. But I don't do it that way. I put the cuscos and I put the outer catheter. Now, once the outer catheter is there, normally with the outer catheter being in position, I will go inside the IVF laboratory and I will start loading the embryo. So this is the inner catheter, as you can see. And again, when you see, this catheter also has marking over it. I hope I'm able to show it to you. So again, it has 1 centimeter, 2 centimeter, 3 centimeter markings over it. So what is important for you to understand is that when this inner catheter is put inside the outer catheter, okay, when your embryos are put inside and when it is going, see, there is a mark here. The minute it touches the mark, that means the inner catheter is going to come out inside. All right, just remember that. So I never calculate how much distance from the fundus is, where exactly in the uterus is it going. I don't really look into all these things. Practically, The minute this inner catheter reaches here at position 2, that is 2 centimeters inside, I will just gently push it. Okay, gently push it and don't release the piston. Okay, don't release the piston. Keep the piston held. Okay, then take out the whole system and just go for checking inside the laboratory. Okay, the way in which we load the catheters, is very simple with the embryo. We have a fluid, then there is air, then there is fluid with embryo, that is media with embryo. Again, there is air, and again, there is some fluid. Okay. And then the total amount of concentrate should be approximately 12 to 15 microliters. Nothing more than that is needed. All right. We almost exclusively do day 5 embryos. Hatched embryos or non-hatched embryos doesn't really matter. Embryo transfer happens on the 6th day of progesterone when it is blastocyst in HRT. On the 7th day post-trigger, if it is a modified natural cycle. No changes in that. No questions regarding that will be answered as a part of this program, because that is a special session which we have taken. Interested people can go through that. Okay. So now I will switch to the video just to show you about this embryo transfer thing. All right. So let me just share my screen. Yeah. See this. This is through the ultrasound probe. You can see it's a half-filled bladder. We will be zooming inside this. Okay, it is good to zoom if in case you want. See, many a times we have done embryo transfers without ultrasound backup. Okay, doesn't really matter. Okay, now you can see the outer catheter has come inside. See that? You can identify the position of the outer catheter there. Just inside the os. Don't keep on manipulating it, moving it up and down, up and down, up and down. All that is really not needed. Okay, once it is there, you can just simply go to the laboratory, start loading your embryos and put the embryo somewhere there with the marker which I'm showing. You don't really need to identify 1 centimeter, 0.8 centimeter. Is the result better with 0.8 or 1? Nothing like that, okay, in practical life situations. And then you come in with the inner catheter. You can see the catheter coming inside now. See that? You can feel the catheter coming inside. And then once you push inside, you will see sonolucent air bubbles inside. Okay. See that? So now it is that is the bubble what you see. It doesn't really actually mean that the embryo is also there. Okay, that is just the bubble. Okay, that sonolucent thing which you saw. Patient is also very happy once they see that. The exact time it takes is this much, because this is a live video. It takes approximately 1 minute for the entire procedure of embryo transfer to finish, and finish very nicely. After the embryo transfer is finished, set of instructions are again standardized. The patient is going to lie down for 5 minutes. After 5 minutes, the patient can go and pass washroom if they are uncomfortable. Okay. Sit in the hospital till the forms are signed. Discharge card is made. That takes another 20 minutes and they go back to office. Okay. No diet restrictions, no restrictions of anything at all. Patients can do whatever they want to do. All right. Though we say that, you should have, there is some form of marketing done about all these things, that no patient has to be in bed rest position, this, that, all these things. In our discharge card, it is clearly written that you don't need any form of bed rest. I'm sure if you Google, there will be some or the other paper which is available, which will prove that in fact, sometimes bed rest can be detrimental. Okay. If you put them at home and they are not doing any activity, they will chew up the head of everybody around. So better is that go to work bindas, nothing happens. Okay. Whatever is destined is going to happen. It is going to happen. All right. Now, I'm going to also answer some questions, because these are the commonest questions for which I am asked a doubt. If there is blood at the tip of outer catheter, does it reduce the success rate? The answer is no. Okay. If there is blood at inner catheter, does it reduce the success rate? Answer is yes. Okay. Because inner catheter ideally should not having any blood. What happens if the inner catheter touches the fundus of the uterus? Nothing happens. Okay. It touches the fundus like how anybody else will touch, and it will just slip because it is a soft catheter. So nothing is going to happen. All right. So don't get worried if something touched the fundus. Even the fundus will not understand with such a small catheter. Understanding? Okay. Then Very important question. In fact, I've made a beautiful YouTube video on it. This is a question which I get at least once in a day, okay, from somebody. Sir, what is your experience with embryo glue? Now, please remember, embryo glue is just 10% hyaluronan instead of the routine 5% which is present in the media. Okay, it is not Fevicol. Okay, embryo glue has got no correlation to Fevicol. Okay, you can't really put Fevicol on the embryo and put it inside. Okay, there is nothing like that in life. Okay, it doesn't increase the success rates. Kindly don't get into that type of feelings. Okay, fine. Next, what is the role of doing mock ET? Okay, I don't do it, but if somebody wants to do it, you do it. And if you think it is a good practice for you, very good. But I don't personally do it. Okay, I never do a mock ET. All right. Another question. Quite a lot of times the embryologist will scream that, oh, don't take out anything. Okay, the embryo is back in the inner catheter. Okay, so the reason why you want to avoid it is by simply just keep this piston. Okay, I told now, once you put the catheter, once you push the embryos inside, don't release the piston here. A lot of people, what they do is, embryo andar dal diya, very happy, they are starting talking to the nurse. No, don't do that. Hold this piston and then gently take it out. See, what typically happens is uterus is not like Taj Mahal. Okay, it does not have so much space inside. It is a very compact organ. This endometrial cavity or the endometrial bed which we try to talk about, it's actually a closed system. Okay, so when you release that piston, no, with that negative suction which develops inside, some embryos can load back. Now, just if in case these embryos have come back inside, nothing to worry. Just pick them up and do a repeat transfer. Okay. Don't get hesitated. Array, now what to do? How much to culture? What to do? What not to do? Nothing to do. Take it and put it in the uterus. Okay. How much time after thawing the embryo should you do the embryo transfer? This is the second most commonest question. It depends on you, how busy you are on that day. See, sometimes if you thaw at around 10 o'clock in the morning, you will get time to transfer at 2:30. Sometimes you are busy doing bowel resection at 2:30, you will get time at 4 o'clock. Okay, so any window after thawing the embryo beyond 2 hours is okay, and less than 7 to 8 hours is okay. All right, between 2 to 7 to 8 hours, if you do the embryo transfer, it is fine. One need not really be like that, like the Swiss military, that I will do the embryo transfer at 3:52. Okay, there is nothing like that in life. All right, it doesn't really matter. Fine. A lot of people again have a very common doubt as far as this embryos is concerned, is that what to do if the cervix is tenosed. All right, shall we use a metal catheter? Shall we use a hard catheter? Shall we use, the one which is with the metal so you can easily pass it inside? It is completely up to you. Okay, it is completely up to you. Remember one thing, 99.9% of the times you will negotiate the cervix. I have seen people who draw beautiful diagrams of the cervix, like this, and ekdam nice curvy linear diagrams are drawn to help them do the embryo transfer. All that is not recommended. It is a waste of time. The catheter will find its way. It is a soft catheter. Just remember, don't push the catheter. All right, just don't push the catheter inside. Okay, it will automatically glow. It will just glide inside the internal os, most of the situations. Just in case the cervix is very, 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 very tough and you think you are not able to negotiate, don't just keep on dilating the cervix, because you will injure the endometrium. Okay, once you injure the endometrium, then your success rate goes down. At any event, if you injure the endometrium, your success rate would go down. Okay, I have had in my entire life just 2 patients with transmyometrial embryo transfer. Both have failed. Okay, so I don't really recommend it. I am not a very big fan of doing it. I am not a somebody, who will say that cervix is closed. No problem. We will put transmyometrial. I don't do that. I post the patient for a hysteroscopy in the next cycle, and you give me whatever cervix, I will open it and give it to you. Okay, because if the menstrual blood is coming out, that means there is a passage. There is a proper passage. Just keep that in mind. It is just that you are supposed to find that passage and do what is necessary at that point in time. Okay. Is there any difference of using a particular brand of catheter compared to the other brand of catheter? The answer is no. The difference is in the hand of the person who is doing the embryo transfer. All right. quite a lot of times I have seen people ask this question to me. I keep the outer catheter, embryologist loads the inner catheter and slowly walks and comes out. Okay, and he gently pushes. The word slowly and gently are the least important things in life out of that. Okay, I put the outer catheter, I go back and I only load the embryos. It is absolutely okay to do that. Okay, catheter will not feel bad if you don't stay with the catheter for the next 1 minute or something like that, and it is absolutely okay. All right. Now, finally, what to do in situations, where unable to remove the mucus plug, unable to remove any jelly, especially the progesterone gel which is kept inside the vagina, and you are unable to see the cervix. In that type of situations, what to do? I normally recommend just putting a gauze piece in that situation. If earbud does not work, a gauze piece with saline and everything will come out. Okay, you don't really need to infuse saline in the vagina and all these things. All that is not recommended. Okay. Then commonly people will ask what to do if there is a highly fixed uterus. Uterus is very high in the cervix. Can we use sim speculum instead of cusco speculum? Of course you can use it, yeah. There is no such problem. Okay. What to do if you are doing embryo transfer in a previous cesarean patient where there is isthmocele? You will see the isthmocele when you are transferring. Okay. You will see the isthmocele when you are transferring. Just avoid it and go inside. Okay. My luteal phase support is very simple. We give progesterone gel twice in a day and duphaston tablet thrice in a day. That's about it. We don't give anything else. So patients are very, very comfortable taking these things even after the embryo transfer, once they are back at home or at their office. Okay. With this, I think I've covered almost every practical aspect on embryo transfer, which I know. Okay. But if there are more questions, I'll be happy to answer.
Yeah. So, shall I ask the questions? And
please ask. Yeah.
So do you notice the uterine contractions? Do you wait for some time before you do
No.
the transfer? Have you ever done that?
I don't do that.
Okay, so do you believe that the embryos can be expelled from the uterus partially, totally into the cervix, and it can lead to cervical pregnancy?
Don't know.
Okay. So you said you don't do mock transfers at all?
I don't do any mock transfers.
And this Kitasato catheter is what you showed just now. So have you used different catheters, or do you individualize the patient and then?
I have used Cook for a prolonged period of time, and then I have switched to Kitasato.
So if there is cervical stenosis, do you do dilatation during the OPU and see, or do you do post them for hysteroscopy like how you said? Or do you use dilapan and dilate?
No, we don't do any of it. It just in case that 1% cases, where the catheter is just not going in. Maybe that's when you do it. Otherwise, all catheters will go inside, madam.
So have you done dilatation during the OPU? Does it alter the success of embryo transfer? Do you check routinely while doing the OPU?
Never.
And do you use local anesthetic jelly onto the cervix in case if the patient is very sensitive?
No.
Do you do embryo transfers under general anesthesia, like using propofol or
Never. Unless the patient is, with that vaginismus.
Yeah.
They will not even allow the probe to go inside. But in that situation, we can use propofol. It does not have any effect on the embryo.
Okay, so when you are using that cusco speculum, so sometimes they suggest that you loosen that screw and those blades of that speculum will close on each other and it will close the internal os. I mean, have you tried that maneuver to?
No.
Okay, have you used transrectal ultrasound in case if the bladder is not full to visualize the placement?
No. If in case with the bladder is not full and you can't visualize, just transfer. What is there to visualize?
So there are studies which say that 500 units of HCG in the culture medium while loading. So do you do that in your practice?
No, I don't do it at all.
And retained embryos. So how much time, you have for
15-20 minutes.
So much?
Yeah, you can put these embryos back in 15-20 minutes. No need to worry.
Okay. Okay. So the time taken between the loading and the transfer. See, many times we
Less
try
than
to.
1 minute.
No, that is for you because you load and you come and you transfer and all that. So if the embryologist is loading and if we are doing it in a situation where it is not very easy to pass the outer sheath and we are struggling to maneuver
The outer sheet, once it is passed, you can keep the outer sheet there and go and load the embryos and come, no? So then they just have to put the inner catheter inside the outer catheter. It doesn't take more than a minute, madam.
Yeah. So do you believe in reducing the exposure of these embryos which are already loaded in the inner catheter to light, temperature? Do you switch on, switch off AC? Do you switch off the light, or you just bring it in like however things are and
I just
yeah. So what is the chance of ectopic pregnancy? Does it depend on the embryo transfer technique?
Day 3 embryo transfers probably have a slightly increased ectopic chances in my experience, okay? But we exclusively do day 5, okay? And I'll tell you one thing, the less media you take, okay, if you are loading with around 12 to 15 microliters of media, that is good. If you are loading with 20-25 microliters, sometimes, okay, you may have a higher risk. But again, it is unproven and it is very difficult to judge.
Yeah. So you told about the bigger uteruses. So what about the smaller uterus? I mean, what care do you take when you transfer into a smaller uterus?
It's actually the same. See, you can't really have a uterine cavity where it is going to be less than 2 centimeters in size. That is going to be a cavity where no pregnancy will occur any which ways. Okay. So the best is to, I have standardized it, just keep it at 0.2. So I mean, you're 2 centimeters inside the os and just push the embryo inside. Okay.
And the time taken for you to push that. See, once you thread the inner sheath into the outer sheath and you are there inside the
1
cavity.
second, as I showed in the video. Not even that much, madam.
So coiling of the catheter, I mean, do you check for it?
No, it will not happen. If you keep it at 2, it will not coil only, no? It will just go straight inside and get pushed. It doesn't coil.
So if you are doing day 3 or day 5, so is there any difference between the two when you do the transfer?
Absolutely not. Number of embryos will differ, nothing else.
Okay. So do you keep this patient after the embryo transfer on the same IVF OT bed for 15-20 minutes or after
5
how long?
minutes. Five.
And how do you shift the patient? Do they get up and walk or do you shift them on a trolley?
How else will they walk? They have to get up only, no, madam, to walk.
No, they shift in a trolley.
Which trolley?
OT trolley. You don't believe in it?
My God, no. They just
Okay.
walk, madam.
Okay. Have you done transfundal transfers like through?
No.
Okay. And you make a checklist of the embryo transfer. Like, was it easy? How long did you take? Was there blood on the tip of the outer sheath, blood on the tip of the inner sheath? And do you audit to know, do you maintain a register wherein you
That
make
register is actually very good to maintain. So we have 3 full-time embryologists here, me being the 4th part-timer. Okay. So of course, all that is maintained. But to be very honest with you, I mean, after so much, I've realized that the embryo which is going to implant will implant. The embryo which is not going to implant will not implant, no matter what. But of course, your technique has to be good. That much I know. Okay.
technique as in like what points? I mean, see, you use a soft catheter, you use ultrasound without, and smaller volume of media, you said?
Smaller volume of media.
Yeah, and not touching the fundus. Are these the 4 important or salient things that
Practically.
Okay. And do you believe in that point of maximum implantation potential, MIP, wherein you draw those lines on a 3D and
No, I don't.
You don't do that?
No.
So in your practice, like exactly from where from the fundus you put, like you said,
maybe 1 centimeter below it.
1 centimeter and below it. So how many cases of cervical pregnancies have you seen in your practice?
So far, none.
Really?
Yeah.
Okay, so you said Atosiban you don't use. Yeah, I think. So your the outer sheet that you showed is it is visualized on the ultrasound, right? The tip is sonolucent.
Not completely, madam. It does not have that ring for the sonolucency to be so profound. But we
Okay.
can come to know that it is inside the internal os when we look at it. Just in case, somebody is more confused, no, you can just reduce the gain of your ultrasound machine. It will make the tip very, very prominent. And then it will become very easy for people to see it.
Okay, and all the time do you visualize the tip of the inner catheter before you push in the?
I never visualize it, in fact.
Oh, then you took the video today just for the demonstration?
Just for demonstration. I actually never look at the ultrasound machine, honestly, when I'm doing the transfer. I just put that at 2 and just push it gently. All right, keep the piston there and just remove it. Okay. I never, in fact, looked where has it gone, right, left, center, mid, up, nothing.
Then yours is clinical touch embryo transfer, not ultrasound guided, isn't it?
No, but ultrasound is for the patient, madam, not for us. They will see, that sonolucent air bubbles. They will be very happy, they've put something inside.
So you haven't found any difference? I mean, have you tried doing it? See, in the initial period of practice, everybody wants to do it under ultrasound guidance just to make sure that, they're doing it the right way.
Mm-hmm.
So you never started off like that and then improvised it like how you're doing it now?
No.
Wow. Okay. Yeah, I think that was quite interesting. And once you pull it out, like you first pull out the inner catheter slowly and then you take out the outer sheath, or do you do it together?
Up to you. I mean, well,
True.
honestly, there is nothing like that. Really.
Yeah. See, sometimes we struggle and sometimes we can't do the transfer. Okay. So do you refreeze these embryos?
Yeah. Provided the patient gives consent, you should refreeze.
Why they will not give consent? Why do you think? I mean,
some people are like that. They are like, embryos are thawed, then the quality will get affected. Every IVF patient knows as much about IVF as much as we know, na? So then they will give us advice. No, not to freeze. We'll do a fresh transfer. We'll do a fresh cycle. Okay, chalo.
oh, okay.
Yeah.
So you never have, like, if you are doing the embryo transfer, you never ask your other full-time embryologist to load it and bring it in? You
Very
obviously.
rarely, madam. Unless I'm out of town. When I'm coming to Bangalore, they will be doing it, the whole thing. But otherwise, this is one procedure which I do. So completely. I like to do the embryo transfers.
Yeah. So in your setup, like you have other colleagues of yours or associates who are working with you. So if you do an audit in a month because you travel so much and obviously, I mean, they also.
Highest success rate is of Chaitali. Highest. Across our career so far.
Okay.
That is the highest. Where whatever we always want her only to transfer. God knows how. Okay. Because she has the best outcomes of embryo transfer.
Okay. And have you standardized, like how you said, put it at 4, do it at 2, and all those things?
Same.
It's the same technique?
Same technique. Everybody will follow it the same way.
And
somebody has their little alterations, madam, here and there. But otherwise, everybody follows it the same way.
Okay. And if you had to train all your fellows or all your the associates, I mean, how did you do it if you're not doing the mock embryo transfers? So you think they should just learn it on a real-time patient?
Best is to learn it with IUI, because IUI catheter is also something which goes inside the uterine cavity only. Okay. Second is to learn it while putting PRP in the uterine cavity, not hysteroscopic PRP. Okay. The routine, many people just put the PRP with the IUI catheter. That is the second way to learn it. So if you have done 15, 20, 30 of these procedures, first embryo transfer you will do nicely only, madam.
Yeah. So I think we have overshot our time. So I think you have to go back. Yeah, thank you so much. Thank you. It was really nice. I hope it adds value to all our viewers here who can go and replicate the same thing in their practice to improve their success rate.